So we are live. We can proceed.
Okay. Hello students, good evening. Welcome to the second LI test series. Hope you have done well in the exam. So let us go through the questions one by one. So coming to the first question. True about intraperitoneal chemotherapy. So what is intraperitoneal chemotherapy? Where is it used? So intraperitoneal chemotherapy is used in commonly ovarian cancer, pseudomyxoma, peritoneal, colon, and gastric cancer. So these are the common conditions where we use. In that, we use for first and second indications. So third and fourth indications, the data is not very good. That's the reason we do not use routinely. Only for very selected patients what we use. So what are the things which you need to know about intraperitoneal chemotherapy? See, the chemotherapy normally delivered IV, right? And it gives a certain concentration at the tissue level. But many of these cancers which have enlisted will have peritoneal deposits, and the penetration of chemo by IV into the peritoneum is less. That is the reason chemo is given directly into the peritoneal cavity with the aim of increasing the concentration and increasing the cell kill. So that is the reason why we give. The second thing is the peritoneal disease should be as minimal as possible. So minimal disease should be there. That's the reason. So we always do cytoreductive surgery and remove as much of disease as possible, then only deliver the intraperitoneal chemotherapy. So the few important things about this topic, this is an important topic. So you know about the names of the trials. So ovarian cancer, what is the intraperitoneal chemotherapy trial? GOG 72. So where they used intraperitoneal taxane and platinum. But this is a normal intraperitoneal, not a HIPEC. What is difference between intraperitoneal IPEC versus HIPEC? HIPEC is the chemotherapy is heated up to 42 degrees centigrade and then it is given. So that is called HIPEC. So HIPEC, increasing temperature is supposed to improve the penetration of chemotherapy. So okay, so let's go to the options. So they're asking about the true statement. It exposes tumor cells to higher concentration of toxic chemotherapy, which is correct. Minimal tumor bulk before intraperitoneal chemotherapy is required. That is also correct option. Hyperthermia enhances cytotoxicity. So the answer is all are true. Also remember what are the other important trials for HIPEC. So ovarian cancer and what are the drugs used. Ovarian cancer, the trial is the Vandryl trial. The drug used is cisplatin. Pseudomyxoma peritoneal, it is a randomized trial is currently going on, but pseudomyxoma, there's a lot of evidence, anecdotal and phase 2 trials where mitomycin C is used. So for pseudomyxoma, what chemo is used? Mitomycin C. For colon cancer, what is the trial? It is Prodige 7. And what drug is used? Oxaliplatin was used. And this was a negative trial. And for gastric cancer, the latest trial, which came this year, is a gastric 1 trial, which has used chemotherapy, which is mitomycin C and also cisplatin. So this is about intraperitoneal chemotherapy and the answer. So remember the names of the drugs, which drugs are used, and the important trials. Coming to the second question, all are alkylating agents except. So one important thing about exam is you need to know all the drugs. Okay, you need to know which class the drug belongs. The second thing is what is the mechanism of action of those drugs. And the third is what all cancers it is used and what are the common side effects and any specific points about the chemotherapy with respect to pharmacokinetics or the pharmacodynamics. Okay, so these are the things which you need to know. So whenever you see any drug, you always need to say, okay, this belongs to this class and this is the mechanism of action. So coming to the alkylating agents, what are they? There is an alkyl group which goes and forms a DNA adducts. which causes cross-linking, and then DNA breaks, correct? So this is a alkylating agent. And you always remember, DeVita gives classification of 5 classes of alkylating agents. One is nitrogen, mustard, nitrosoureas, triazines, alkyl sulfonates, and ethylamines or methylamines. Okay. So what are the night drugs? So 5 classes. You remember alkylating agents, 5 classes. And first, nitrogen mustard is a very commonly used chemo drugs. Cyclophosphamide, ifosfamide, meclorithamine, melphalan, chlorambucil. So even if I wake you up in sleep and ask you, you should be able to say what are nitrogen mustards. You should be able to tell all the names of the drugs. This is the very basics in oncology, medical oncology. So what are the nitrosoureas? So nitrosoureas are carmustine and lomustine and triazines. Zine, then it's there in the name, dacarbazine. Yeah, zine and zine, dacarbazine and temozolomide. And alkyl sulfonates. Alkyl sulfonates are bendamustine and busulfan. And ethylamines, so methylamines, the one thing you need to remember is the thiotepa. Thiotepa is used in bone marrow transplant. Autologous, right? Usually used for primary CNS lymphoma. So remember specific point. So the question, all are alkylating agents except alkyl sulfonates, yes, nitrogen mustard, yes, triazine, yes, urine analogs are anti-metabolite agents. So the answer is D, urine analogs. Coming to the Calvert's formula. Calvert's formula, you need to remember, which is GFR plus 25 multiplied by AUC. So let us, this is used for carboplatin. When I have to give dose a patient with carboplatin, I usually dose it AUC is area under curve 1.5 or AUC 2, AUC 5, AUC 6, and sometimes AUC 7. So this is the area under curve. If I have to give AUC 5, patient EGFR we calculate by Cockcroft-Graf formula. So EGFR is 80 plus 25, 105 into 5. So 125 is the dose of carboplatin. So how will you dose cisplatin? No formula. It is per meter square. The common dose of cisplatin is 3 weekly. We give 75 to 100 milligram per meter square. Weekly dose of cisplatin is 40 milligram per meter square. So you also need to learn about the common chemotherapy drugs, in what saline, in what fluid they are mixed, whether normal saline or 5% dextrose. Cisplatin is always used with normal saline. Carboplatin is always mixed with 5% dextrose. Oxaliplatin is given at 130 mg per meter square in normal saline. Doxorubicin is usually used at 75 or 60 mg per meter square used in normal saline and 100 ml. So the answer is carboplatin. Rest all the chemo drugs is based on the body surface area. Next question, what is the main toxicity of paclitaxel? What is paclitaxel? It is microtubule agent, right? So taxane. So what are the microtubule agents? You always revise. Okay, microtubule agents are Wink alkaloids and taxanes. So both of them act on the tubulin. So the tubulin molecules form microtubules, right? So Wink alkaloids bind to the plus side of the microtubules, and taxanes go and bind to the inside of the microtubules, and they cause, Wink alkaloids cause destabilization and taxanes cause stabilization. So opposite mechanisms of action, but ultimately the mitosis doesn't proceed and then cell undergoes death. Okay, but most important toxicity of both these agents is a peripheral neuropathy. Okay, so paclitaxel causes neurotoxicity, that is the main toxicity. So after 4th cycle or 5th cycle, patient will have sensory neuropathy. Sinus bradycardia is another common thing. It is seen during infusion. Around 30% of the patients, it is reversible sinus bradycardia. Neutropenia is not so common, but still is possible. And ototoxicity is common with the cisplatin, not with the taxane. So one of the most dreaded toxicity of paclitaxel is the anaphylaxis because of Krimafer. So that is about this question. The answer is peripheral neuropathy. False statement about taxanes. Okay, again, paclitaxel is very commonly used chemotherapy drug. You need to know in and out of the drug. So paclitaxel, when you write the order, you write injection paclitaxel 175 mg per meter square in 500 ml normal saline over 3 hours. Okay. So if you are working in a cancer center, if working as a registrar, you will be able to answer almost 90% of these questions. Most of the questions in the exams actually are clinically oriented. Okay. And if the paclitaxel is given at a weekly dose, we use it 60 milligram per meter square in the same 500 ml over 1 hour. So 3 hours and 1 hour is correct answer. Infusion time of docetaxel is 1 hour. That is also correct. Tacitaxel is a oral taxane. That is also correct. So on the answer is all the statements are correct. Coming to the next question. First, false about bleomycin. Okay. So bleomycin is one peculiar chemotherapy drug which comes under miscellaneous category, or sometimes it is also included in the anti-tumor antibiotics. So there are two types, right? Anthracyclines and non-anthracyclines. And bleomycin, the main mechanism of action is by the free radical generation. So after it goes into the body, it combines with iron and generates reactive oxygen species which damage the DNA. And it is cell cycle specific also. It acts in the G2 and M phase. This is one of the drug which acts in the G2 phase, okay, bleomycin. And it is cell cycle non-specific. This is a wrong answer. Free radical mediated injury, yes, that is there. Dose limiting toxicity is pneumonitis. This is one of the dreaded toxicity. It is idiosyncratic, but in some patients it is predictable, especially with increasing age, smoker, or if the dose is more than 400. Cumulative dose is more than 400. GCSF increases pulmonary toxicity, yes, because when you use GCSF, neutrophils are increased. These neutrophils go and sit in the lung vessels, and then this increases the formation of reactive oxygen species. That's the reason pulmonary toxicity is increased. So the answer is A, cell cycle non-specific. Next question, all of the following are true about bortezomib. So what is bortezomib? It is a proteasome inhibitor. What is proteasome? You remember ubiquitin proteasome pathway, right? So what does it do? It degrades the proteins. So when proteasome is inhibited, all the abnormal proteins will accumulate in the cell. And this accumulation of abnormal proteins leads to cellular dysfunction and cell death. So that is a mechanism of action of bortezomib or proteasome inhibitors. So there are two important proteasomes, 26S and 20S proteasome. You need to remember bortezomib is a reversible inhibitor of 26X proteasome. So the proteasome inhibitors are categorized into boron derivatives and epoxy ketone drug class. Okay, so bortezomib and ixazomib are the boron class, and epoxy ketone class is a carfilzomib. So in myeloma, we usually use bortezomib. When you say VRD, V is Velcade, that's a brand name. That's a bortezomib. This is the first line of treatment in all the patients with myeloma. When somebody progresses on bortezomib, we use carfilzomib as a second line. So this is given intravenously. Bortezomib is given subcutaneously. Intravenously, we have stopped using because of increasing neuropathy. So carfilzomib is epoxy ketone class and also acts on the 20S ribosome, not on the 26S. It is used in multiple myeloma. It causes peripheral neuropathy. So what is the wrong? They're asking the wrong option. Wrong option is the epoxy ketone class, which is carfilzomib. Bortezomib comes under the boron class. So all are HDAC inhibitors except. So broadly, you remember the chemotherapy drug classification. What are they? Alkylating agents, then anti-tumor antibiotics, then anti-metabolites, then microtubule agents, and the last categorization is a topoisomerase inhibitors. So these are all the drugs which act on the DNA level. Okay, but there are some drugs actually which are the epigenetic level. So what is epigenetics? Epigenetics is broadly two things: DNA methylation or demethylation, and histone acetylation or deacetylation, and also methylation as a lesser component. So what happens if DNA is methylated? Add methyl, DNA is inhibited. So DNA replication doesn't happen if you add a methyl group. It obstructs the replication. If you add acetyl group to histone, histone covers the surface of DNA. What happens if you add acetyl? It opens up and increases the DNA multiplication. So the epigenetic drugs which are used are the DNA methyl transferase inhibitor. So we are preventing the transfer of methyl group so that we want to increase the DNA multiplication. Okay, histone deacetylase inhibitors. That means deacetylation is inhibited. So we are adding acetyl group. Again, we are increasing the DNA multiplication. So many of these cancers are caused because of the inhibition of the DNA replication, especially the tumor suppressor agents. So epigenetic drugs will act. So DNA methyl transferase inhibitors, what are the examples? Decitabine, azacitidine. And HDAC inhibitors are oronostat, romidipsin, entinostat. So the answer is azacitidine, which is a DNA methyl transferase inhibitor. So what are these drugs used? Where are these drugs used? All the HDAC inhibitors are commonly used in CTCL, cutaneous T-cell lymphoma, or PTCL, peripheral T-cell lymphoma. Azacitidine, decitabine are used for acute myeloid leukemia or myelodysplastic syndrome. Okay. Come to the next question. What are the TKIs which are active against T315I? So this is very specific mutations. So when we do BCR-ABL, we will look at 3210, 319, right? Which are a minor transcript. This is the initial BCR-ABL. But after we start imatinib, dasatinib, or bosutinib, if you will follow up the patients, and BCR-ABL increases. And what test is done that time? This BCR-ABL, and the test done that time is called IRMA, imatinib resistance mutation analysis. So in the IRMA, one thing what we look for is a T315I. This is a very specific mutation which only one drug acts, which is the ponatinib. Okay. So imatinib, dasatinib, bosutinib are the initial generation. Imatinib is the first generation. Others are the later generations. Ponatinib is the drug which is developed specifically for T315I. Other important points about ponatinib, it is usually given 45 milligrams per day or 30 milligrams per day, and we also add aspirin. What drug is given along with ponatinib? Aspirin, because it increases blood clot formation. Okay. All the cardiovascular events happen. And nilotinib also causes cardiovascular events, but which has more propensity, it is the ponatinib. There is a new drug called asciminib. Asciminib, all of you need to know because it is recently come into the guidelines as one of the first line drugs. How is it different from all these drugs? So all these drugs act at the ATP binding site of BCR-ABL, but asciminib acts by mechanism called STAMP. Okay, so it is a specific binding to myristoyl site of the ABL protein. So it binds at a different binding site. Okay, and it acts across all types of imatinib. So these are radial mutations. Okay, except for T315I. So even though asciminib is a new molecule, the drug of choice for T315 is still ponatinib only, not asciminib. So imatinib is used in all the following ways. Imatinib is used in actually many conditions. pH positive, yes. pH positive ALL, yes. GIST is the drug of choice. ALL, not all ALLs. Okay. Imatinib or dasatinib is used only for pH positive ALL. So the answer is ALL. Which of the following is not an EGFR inhibitor? So EGFR, epidermal growth factor receptor. EGFR 1, 2, 3, 4 are there. 2 is also called HER2. And EGFR is a molecule on the cell surface. And it has an extracellular domain and intracellular tyrosine kinase domain. Most of the bigger molecules like monoclonal antibodies we use act on the extracellular site, which include cetuximab, panitumumab, act on the extracellular site. And tyrosine kinase domain is inhibited by all these TKS, which is gefitinib, erlotinib, afatinib. So when we talk about EGFR, we usually talk about tyrosine kinase domain inhibitors, and the first generation is gefitinib, erlotinib. Second generation is afatinib, dacometinib. The third is osimertinib. There are new molecules like lazertinib and other amivantamab. So these are all the anti-EGFR agents. And EGFR2 includes all the trastuzumab, lapatinib, TDM1, everything as per HR. So look at the answers: gefitinib, erlotinib, afatinib, or EGFR agents. Crizotinib acts against ALK inhibitor. So what topic is this? This topic is about the targeted therapy. So there is a very nice table in Harrison. You go through all the list of target therapeutics. Most of the drugs are covered in the table. That alone is sufficient. Now coming to idelalisib, copanlisib, buparlisib or POT. They are PIK3 inhibitors. There's nothing explanation here. You need to remember the names of the inhibitors. Common is the alpacilib. And all these LIP-CIPs are PIK3 inhibitors. What are the RET inhibitors? You remember RET inhibitors are used for medullary thyroid cancer. Vandetanib and cabozantinib are the RET inhibitors. CDK4/6 inhibitors are palbociclib, ribociclib, abemaciclib. And BTK inhibitors are used are ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib. So you will need to remember the pirtobrutinib because this is a new molecule. The trial had come last year. Pirtobrutinib acts actually very well compared to the BTK inhibitors. One peculiar thing is, when you read most of these drugs, the initial generation would be reversible inhibitors and the later generation would be irreversible inhibitors. Here, pirtobrutinib is a reversible inhibitor and other BTK, initial BTKs are the irreversible inhibitors. So, pirtobrutinib and other agents which you need to remember. So, where do you use BTK inhibitors? We use in CLL. Okay, where do you use CDK inhibitors? Used in breast cancer. RET inhibitors, medullary thyroid cancer. PIK3 inhibitors are used commonly in the breast cancer. What is the next question? What is the mechanism of anthracycline-induced myocardial damage? Okay, so what are anthracyclines? Anthracyclines are anti-tumor antibodies. What do they do? Anthracyclines go and generate free radicals. Also, anthracyclines lead to DNA breaks, which is indirectly because of the free radical generation, and also they inhibit topoisomerase 2. But the main mechanism is DocTutorials and DNA breakage, and the myocardial damage happens because of the direct generation of reactive oxygen species. DNA damage of myocardial cells or doxorubicin doesn't happen. So the answer is A, reactive oxygen species. What are the other agents in anti-tumor antibiotics? Anthracyclines, you know, doxorubicin, daunorubicin, rubicin, and rubicin. Non-anthracycline agents are mitomycin C, actinomycin D, So remember the names of all the drugs. What is belotecan? So whenever you hear tecan, you always remember the class of drugs. What will it start? Topotecan, tecan, and then again belotecan. So what are all these tecans? They are the topoisomerase inhibitors. Topo inhibitors are categorized into first one is all the topoisomerase and belotecan. Topoisomerase 2s are categorized into epiphotophyllotoxins, and anthracyclines. Epiphotophyllotoxins are etoposide, tenoposide. Anthracyclines, you know already, the topo inhibitors. So topotecan are all the camptothecin analogs, not conjugates. Non-camptothecin agents are the anthracyclines, epiphotophyllotoxins, and topoisomerase 2 inhibitors are again these molecules. So what is the answer? The answer is camptothecin analogs. Early diarrhea due to irinotecan. So irinotecan diarrhea, you remember, it is categorized into acute diarrhea and early diarrhea and late diarrhea. Early diarrhea happens within 24 hours of treatment. Late diarrhea happens after 24 hours. What typically happens is we'll be giving the drug. At the end of the day, patient will have shivering, patient will have some diarrhea, lot of sweating, and muscles will be twitching. So this classically we see in the OP poisoning, right? It actually looks very similar to OP poisoning, but with a milder way. So what does it happen? It's because of acetylcholine esterase inhibition. So increase in acetylcholine causes early diarrhea. And late diarrhea is caused because of the SN38, which is the active moiety of the irinotecan, which is actually attached to glucuronide group and secreted by a bile. So the bacteria in the gut will break the glucuronide and release the free SN38, which causes late diarrhea. So the answer is early diarrhea happens within 24 hours of drug administration. Intercalators are TROP2 in targeting agents, which includes again topoisomerase 2 inhibitors, I told, epiphotophyllotoxins and other agents. So etoposide, tenoposide. Other agents are the anthracyclines. Anthracyclines are also called intercalators, okay, which includes doxorubicin. What is irinotecan? TROP1, topoisomerase 1 inhibitor. Etoposide, topoisomerase 2 inhibitor, but it is still not an intercalator. Topotecan is topoisomerase 1 inhibitor. Now coming to the next question. Which of the following is used in ALL? Okay. So ALL, what are the drugs which are used? Clofarabine, cladribine, fludarabine, and capecitabine. So in the capecitabine is what? It is an all of them are antimetabolite agents, and capecitabine is used for all the solid tumors. Clofarabine is used in ALL. Cladribine is used in hairy cell leukemia, and fludarabine is used in CLL. Okay, so CLL FCR regimen is commonly used. That is a fludarabine based regimen, and cladribine is used for hairy cell leukemia. So important point about all these three agents is they cause delayed neutropenia and prolonged duration. So most of the chemo drugs, they recover within 3 weeks. But when these medicines are used, the recovery might take as long as 8 weeks. There is a specific point about clofarabine, cladribine. You remember what disease they are used? The pencil is not working. what diseases they are used, and also what are the specific points. Now coming to the next question. What is the false about gemcitabine? Gemcitabine, what class it is? Gemcitabine comes under anti-metabolite. Okay, so yeah, so gemcitabine comes under anti-metabolite agent. And what is the problem? Infusion time is 60 minutes. So again, you will have to work in the ward to know these kind of things. It is very commonly used 30 minutes. Not at a time. Gemcitabine requires an enzyme to be converted into active moiety. So if we give at a very short time, the gemcitabine, the enzyme is saturated and most of the gemcitabine goes over in the urine. But if you give it a longer time, more and more gemcitabine gets accumulated in the cell, which leads to more toxicity. So if you give more than 30 minutes, there is increase in toxicity. Less than 30 minutes, it doesn't work. So the ideal time is 30 minutes. Myelosuppression is very common. More toxicity is expected in women because the clearance is lesser. This is also wrong. So what is the wrong false statement? The answer is A. It is given over 30 minutes, not 60. Now coming to the next question. Cerebellar dysfunction is associated with very specific point about cytarabine, especially high dose cytarabine. So in AML ward, when you work, patients after 3+7 induction will go for high DAC or IDAC. So we give around 2 to 3 grams per meter square of cytarabine. And one dreaded toxicity is the cerebellar dysfunction. I had one patient who had, unfortunately, we lost him because of the neurological cerebellar dysfunction. There is no specific antidote for this, and usually they will have a residual deficits, and we cannot recharge cytarabine again. Another common side effect of cytarabine is the keratitis. That is the reason we use steroid eye drops for any patient who is undergoing chemotherapy with high dose cytarabine. Other things like cladribine, clofarabine, and gemcitabine do not cause any cerebellar dysfunction. Cladribine, the side effect is the prolonged myelosuppression. Sorry, pencil is not working. Prolonged myelosuppression. Clofarabine is used in ALL, especially TAL, and gemcitabine causes neutropenia. It used in many of the solid tumors. Most important biochemical modulator of 5FU is. So, okay. So this is one very interesting thing about the leucovorin. So what is leucovorin? It is folinic acid. Leucovorin is used in combination with two drugs. One is with methotrexate, another is with 5FU. Okay. So whenever, I think I've already told about high dose methotrexate in previous class. So when you use high dose methotrexate, we use leucovorin to rescue the normal cells. Sorry. So it is used to rescue the normal cells. And 5FU is used to, so the pencil is not working. I'll just tell. So leucovorin is used to rescue normal cells, and in 5FU to actually increase the cytotoxicity. What happens in 5FU? When 5FU is given, it goes into the cell and gets converted into 5-fluorouridine monophosphate, deoxyuridine monophosphate, and then gets incorporated into the cell DNA. And after that, it goes and inhibits the thymidylate synthetase enzyme. And it is actually a very weak inhibitor of the enzyme. And what if you use leucovorin goes and stabilizes the complex, which increases the cytotoxicity. In methotrexate actually inhibits the folate metabolism, and normal cells will also not get the folic acid, which is important for the 1-carbon metabolism. So leucovorin is used to rescue the normal cells, and preferentially the cancer cells are not rescued because they don't have a transporter for leucovorin. Okay, so most important biochemical modulator of 5 is the leucovorin. The answer is LV. Next question. Most alkylating agents. So alkylating agents, secondary malignancy, it's a leukemia. which is called related AML or therapy related MDS. It is classified into two types, early and late. So early, late. Early happens around 1 to 3 years, late happens around 5 to 7 years. Early happens because of etoposide, E for E, early. Etoposide, tenoposide, all the phyllotoxins causes early, and late happens because of anthracyclines. The common genetic abnormality seen in early AMLs is a 11q abnormalities, which is a MLL protein, and late it is 5 deletion and 7 deletion. Remember, 5 to 7 is 5 and 7 deletion. Early is etoposide, 11q deletion or MLL. So common cancer is acute leukemia is the answer. Hodgkin form of cancer CMLs are not common. Second malignancies. What are the cytotoxic effects of antifoliates or mediated? Inhibit the folic acid metabolism. So DNA edits form? No. Free radical formation, I already told about. So when methotrexate goes into the cell, there will be 7 glutamate residues are attached, and this increases the retention of methotrexate in the intracellular space, which increases the toxicity. So answer is a polyglutamation. So what is the process involved in cisplatin resistance? So resistant mechanisms is again important topic which all of you need whenever reading drugs, especially for the common drugs like platins, anthracyclines. Just list down the important mechanism of action which is given in data. So the answer here is increase in efflux, intracellular detoxification by glutathione, increased DNA repair by NER is a nucleotide excision repair. So cisplatin forms actually works like an alkylating agent only, right? So it forms attacks and then that nucleotide is removed. So repair happens because of nucleotide excision repair. The answer is all. And the last question. Toxicity profile of carboplatin mainly includes. So platin. There are 3 important platins. This is nephrotoxicity, phototoxicity, and rarely neurotoxicity. Nephrotoxicity importantly, protein leak and hyponatremia. Carboplatin causes more of a myelosuppression. Oxaliplatin causes neuropathy. Okay, you need to remember all these things. Very, very important. Nephrotoxicity by cisplatin, neurotoxicity by oxaliplatin, phototoxicity by cisplatin, myelosuppression by carboplatin. The answer is myelosuppression. So what is a orally active platinum compound? This is again a memory-based question. The answer is citraplatin. Nedaplatin, lovaplatin, cisplatins are all IV molecules. So that ends this session. All of you write down the classification of chemotherapy. List down all the important drugs in that. Try to recollect. If you have a friend, discuss with your friend. For each drug, tell about what class it belongs, what is the mechanism of action, what are the common causes cancers it is used, what are the important side effects. Okay, then you will be able to answer all of these questions, and if possible, work in any of the cancer centers. So we'll conclude the session. Thank you all for joining. Have a good night.